Welcome to the deep dive. Today, we're tackling a really important health topic, cardiovascular disease.
hmm
You probably hear it called heart disease a lot, right?
Yeah.
But it's more complex than that, and honestly, the impact is just massive.
It really is. Globally, we're talking, what, 17.7 million deaths back in 2015.
Yeah.
Number one cause worldwide.
Exactly. And here in the U.S., it's been the leading cause of death since 1975. Think about that. 1 in every 4 deaths.
Wow.
And the cost, financially, it's staggering. Hundreds of billions every year.
Yeah. The source mentioned $237 billion annually in indirect costs alone.
And it's only projected to go up. $368 billion by 2035, they estimate. It's huge.
Yeah.
So our mission today in this deep dive is to get past that general heart disease label. We want to really unpack the specific conditions under the cardiovascular disease umbrella. We're
Yeah.
using insights from a detailed medical resource to do this. Think of it as a shortcut for you to get properly informed on something critical while uncover some surprising stuff, but also really practical, actionable knowledge.
That's a great way to put it. Because, the cardiovascular system, the heart, the blood vessels, it can have a lot of different problems. Things like infections, endocarditis, or rheumatic heart disease affecting the valves.
Right.
But for this deep dive, we're zeroing in on the 4 main conditions that really define CVD as we generally discuss it in this context.
Okay, the big 4. What are they?
First up is coronary artery disease, or CAD, sometimes called coronary heart disease, CHD.
Okay.
This is basically when blood flow to the heart muscle itself gets reduced, and that can cause angina chest pain or a myocardial infarction.
A heart attack.
Exactly, heart attack, or even lead to heart failure down the line. This one, it accounts for a huge chunk of CVD cases, maybe a third, potentially up to half.
Wow, that's significant.
Definitely. Then number 2 is cerebrovascular disease. This is the one we associate with strokes or cerebrovascular accidents and also TIAs, transient ischemic attacks.
The mini stroke.
Sort of, yeah. Temporary stroke symptoms. Next, we have peripheral artery disease, PAD. This mainly hits the arteries in the limbs.
Legs, mostly.
For the legs, yeah. It can cause that cramp-like pain when you exercise called claudication.
Okay.
And finally, number 4 is aortic atherosclerosis. This is linked to aneurysms, those bulges in the aorta, either in the chest, thoracic, or the abdomen. So those are the 4 we're really digging into.
Okay, so we've got the MAPCAD, cerebrovascular, PAD, aortic atherosclerosis. But what connects them? Is there like a root cause or a fundamental process driving so many of these?
That's the crucial question.
Okay.
And while, yes, there are different specific triggers like an embolus, a clot causing a stroke, or maybe rheumatic fever damaging heart valves,
Right.
the most significant common denominator, the thing underlying most of this, is a process called atherosclerosis.
Atherosclerosis.
Yeah.
Okay. The hardening of the arteries people talk about.
That's the one.
Yeah.
It's really the silent culprit behind so much CVD. Think of it as a progressive disease process happening inside your arteries and your aorta.
So what's actually happening?
Well, it's like a slow buildup inside the pipes.
Mhm.
It causes the vessels to narrow, that's called stenosis, or even get completely blocked, which reduces or stops blood flow.
Okay.
And it's not just simple gunk, it's complex. It involves factors like dyslipidemia, unhealthy blood fats.
Cholesterol and triglycerides.
Exactly. Plus inflammation, immune system responses, and something called endothelial dysfunction, basically. The inner lining of the blood vessel isn't working right.
Got it.
All these things kick off the formation of what's called a fatty streak. That's like
Huh.
the earliest sign, the first step in developing an atherosclerotic plaque.
A fatty streak.
Yeah. And here's the really surprising part, our source highlights. This whole process, this initial fatty streak formation, can start incredibly early, like even in childhood.
Wow, childhood. Seriously, that's pretty alarming. So the foundations are laid way earlier than most people think.
Absolutely. Which makes lifelong habits so critical, doesn't it?
Yeah, definitely. So what happens after the fatty streak?
Well, it progresses. The artery's inner layer, the intima, thickens up. Immune cells called macrophages gobble up lipids, becoming foam cells.
Foam cells, okay.
Right. More stuff gets deposited, like extracellular matrix. Then smooth muscle cells from the artery wall start multiplying and moving into the plaque. All this builds up into the atheroma, the plaque itself.
So it just grows bigger and bigger.
It can, yeah. And as these plaques or lesions expand, cells in the deeper layers can actually die off. This attracts more immune cells, triggers calcification hardening, and turns it into these hardened atherosclerotic plaques.
Like rust building up and making a pipe narrow and brittle.
That's a pretty good analogy, yeah. Constricted and hardened.
So we get the biology, the atherosclerosis, but if this has been happening for ages, why the big increase in CVD rates over recent decades? There must be more to it, right? Societal factors.
Oh, absolutely. You have to connect it to the bigger picture.
Right.
The rise in CVD is deeply, deeply tied to how our societies have changed. Think about the shift from physically demanding work,
Farming, manufacturing.
right, to mostly sedentary jobs, offices, computers, then add modern consumerism, technology,
Hmm.
longer work hours, longer commutes maybe.
Less free time for moving around.
Exactly, less dedicated leisure time. It creates this environment that kind of inadvertently promotes these health issues.
So how does that translate directly?
Well, these societal trends feed directly into lifestyle factors that fuel atherosclerosis. Widespread physical inactivity is a huge one.
Hmm.
Diets that are often high in calories, loaded with saturated fats, sugars,
The typical Western diet, unfortunately.
yeah, often. And these patterns aren't just linked to atherosclerosis directly. They also contribute to other metabolic problems like metabolic syndrome, type 2 diabetes, hypertension, high blood
And
pressure.
those are all common in people with CVD, right?
Highly prevalent, yes. It's
Okay.
all interconnected. It's sort of a consequence of our modern lifestyle in many ways.
Okay, this is making sense. We know what CVD is, the different types, and how it develops with atherosclerosis, fueled by modern life. But now, for everyone listening, the really practical question. What puts us specifically at risk? And crucially, what can we actually do about it? Which factors can we control?
Right, and this is where it gets really empowering, I think. Understanding risk factors is key to prevention. There's a massive global study, Interheart, covered 52 countries.
Wow.
And they found 9 modifiable risk factors, things you can change, that accounted for an incredible 90% of the risk for a first heart attack.
90% from just 9 things. What are they?
Okay, number 1, hugely significant, smoking. The study found smoking alone was responsible for 36% of the heart attack risk in the population they studied.
36% just from smoking. That's massive.
It is. Then, dyslipidemia, those unhealthy blood fats we mentioned, hypertension, high blood pressure, diabetes, abdominal obesity carrying extra weight around the middle. Psychosocial factors, like chronic stress, not eating enough fruits and vegetables, regular alcohol consumption, and physical inactivity. 9 factors.
That list covers a lot of modern lifestyle issues we just talked about.
It really does. And these findings aren't isolated. Other huge studies, like the Framingham Heart Study, which has been going on for decades, and N18 East III, a big U.S. health survey,
Right.
they found very similar strong links. Unhealthy lipids, high blood pressure, smoking, glucose intolerance, prediabetes, or diabetes. These consistently show up as major predictors.
So the evidence is really solid?
Overwhelmingly so. In fact, those studies showed that something like 60% to 90% of coronary heart disease events happen in people who had at least one of these major risk factors.
Wow. So having even one makes a big difference.
It really does. And based on all this, the American Heart Association, the AHA, has their Life Simple 7, well, now often updated, but the core recommendations are clear. Don't smoke, be physically active, eat a healthy diet, maintain a healthy weight, and keep your blood pressure, cholesterol, and blood sugar levels in check.
That list. It's comprehensive, but it could feel overwhelming. If someone listening wants to start somewhere, focus on 1 or 2 things for the biggest impact. What would you suggest based on that Interheart data?
That's a really practical question. All 7 are important for overall health, absolutely. But if you're looking for the biggest bang for your buck based on that 90% risk attribution, quitting smoking, if you smoke, is arguably the single most impactful thing you can do, given that 36% figure.
Okay, smoking first.
After that, focusing on physical activity and improving diet, more fruits, vegetables, less saturated fat and sugar, those are powerful because they can positively influence several other factors at once, like weight, blood pressure, cholesterol, and blood sugar.
So start there, small, consistent changes.
Exactly. It's not about perfection overnight. It's about direction.
Okay, those are the things we can change. What about the things we can't? The non-modifiable factors.
Right. We have to acknowledge those too. Family history is a big one. If you have a first-degree relative, a parent or sibling who developed CVD or died from it relatively young, the definition is usually before age 55 for men or 65 for women. That's an independent risk factor.
So genetics plays a role.
It certainly does. Then there's age. Simply getting older increases risk. The prevalence of CVD climbs pretty steadily with each decade.
Makes sense.
And gender. Men tend to develop CVD earlier than women on average, though that gap narrows significantly after women go through menopause.
Interesting. Does risk play out differently between men and women?
There's some evidence suggesting that yes. For example, the source mentions that having diabetes or smoking heavily, say more than 20 cigarettes a day, might increase CVD risk even more in women compared to men with the same factors. So nuances exist.
Good to know. Any other factors?
Yeah, the resource briefly mentions a few others associated with increased risk. Things like having HIV, a history of radiation therapy to the chest area, microalbuminuria, that's a kidney damage marker, and also elevated inflammatory markers in the blood.
What about specific foods people argue about, like meat or coffee?
Yeah. Things like meat consumption, fiber intake, coffee. The evidence there is often more controversial or debated. It's really hard to design studies on specific dietary components without lots of potential biases creeping in, making it tricky to draw firm conclusions about their independent effects.
Okay, so focus on the big established factors.
Primarily, yes. That's where the strongest evidence lies for prevention.
So we know the risks. Now, what does it actually feel like? How does CVD present itself? You mentioned it can be silent, which is scary.
It really can range dramatically, from completely asymptomatic, no symptoms at all.
Like someone having blocked arteries but feeling fine.
Exactly. Maybe they find it on a scan for something else, or they have silent ischemia where the heart muscle isn't getting enough oxygen, but there's no pain signal. That happens.
Wow.
All the way to the other end of the spectrum. Classic, acute, dramatic presentations. A sudden heart attack, a major stroke.
Okay, let's break down the symptoms for the main types. Coronary artery disease first.
Right, CAD. The typical symptom is angina, usually described as a substernal behind the breastbone crushing, pressure, or squeezing pain.
Okay.
It might radiate, often to the inner part of the left arm, sometimes the neck, jaw, or even the back. And it can come with other things: nausea, vomiting, palpitations, sweating diaphoresis, feeling faint, or sadly, even sudden death.
That classic movie heart attack scene.
It captures some elements, yeah. A key indicator is chest pain that's brought on by exertion, by physical activity, and then gets better when you rest or take nitroglycerin. That pattern strongly suggests ischemia, lack of blood flow.
But you mentioned atypical presentations.
Yes, and this is crucial, especially for women. Older adults or people with diabetes, they might not have that classic chest pain. An acute MI, a heart attack, could present only with symptoms like sudden dizziness, unexplained nausea, extreme fatigue, or shortness of breath.
So you can't just rely on chest pain as the only warning sign.
Absolutely not. Especially if someone has known CAD or multiple risk factors. Any unusual sudden symptom warrants attention.
Okay. What about cerebrovascular disease stroke and TIA?
Here, the hallmark is sudden neurologic deficits. Something suddenly isn't working right in the brain's control system.
Like weakness or speech problems.
Exactly. Sudden onset of weakness or numbness, especially on one side of the body, face, arm, or leg. Sudden confusion, trouble speaking or understanding speech, dysarthria or aphasia. Sudden trouble seeing, sudden trouble walking, dizziness, loss of balance or coordination, or a sudden severe headache with no known cause.
And the difference with a TIA?
The key differentiator is time. For a TIA, these symptoms resolve completely, usually within minutes or hours, but always within 24 hours. But a TIA is a major warning sign that a full stroke could happen.
Got it. What about strokes in the back of the brain? You said those can be subtle.
Yeah, posterior circulation strokes can be tricky. Symptoms might be less obvious, like ataxia, clumsiness, or lack of coordination nystagmus, which is involuntary eye movement, dizziness, vertigo, headache, fainting, nausea, vomiting. Less classic weakness or speech issues sometimes.
Harder to recognize, potentially.
Can be, yes.
Okay, moving to the limbs. Peripheral artery disease.
PAD. The classic symptom is claudication. That cramp-like muscle pain, usually in the calf, but sometimes thigh or buttock, that comes on with walking a certain distance and goes away fairly quickly with rest.
Because the muscles need more blood when working.
Precisely. The narrowed arteries can't deliver enough. In more severe PAD, you might see changes in the leg or foot skin, looking pale or bluish, feeling cold, maybe hair loss on the leg, or sores or ulcers that don't heal well.
Right. And finally, aortic aneurysms. You said often asymptomatic.
Often, yes, especially when they're smaller. Symptoms tend to arise when the aneurysm gets large enough to press on nearby structures.
Like what?
For a thoracic aneurysm in the chest, it might press on the airway, causing cough or shortness of breath, or the nerve to the voice box, causing hoarseness, or the esophagus, causing trouble swallowing.
And abdominal ones?
Might cause a deep pain in the abdomen or back, or a pulsating feeling near the navel. But the scary presentation for both is rupture.
Which is sudden and severe.
Extremely. Sudden, tearing or ripping chest or back pain for a thoracic rupture. Sudden, severe abdominal or back pain, maybe fainting for an abdominal rupture. It's a surgical emergency.
Okay, so beyond symptoms, how does a doctor check for these things, the physical exam?
Absolutely essential. It starts with just looking at the person, any signs of distress, skin color, breathing effort, then checking the neck. Feeling the carotid artery pulses, listening with a stethoscope for bruits, that whooshing sound of turbulent flow through a narrowed artery. Looking at the jugular veins for pulsations can give clues about heart pressure.
And the heart itself.
Listening carefully to heart sounds the rhythm. Any extra sounds like murmurs, clicks, or gallops. Feeling the chest wall for the point of maximal impulse, the main heartbeat, or any vibrations called thrills.
And the limbs.
Crucial. Checking pulses in the arms and legs, brachial, radial, femoral, popliteal, pedal pulses. Comparing them side to side. Looking for signs of poor circulation like skin changes or temperature differences. It's a head-to-toe assessment, really.
So, recognizing symptoms is one thing, but then there's the evaluation. How do doctors assess CVD risk and diagnose it? And you mentioned prevention is key. How does that work in practice? How do we get ahead of this?
Right. Getting ahead is the goal. As we said, the clinical history, asking detailed questions about symptoms, family history, risk factors, and that thorough physical exam are still the cornerstones.
Okay.
Certain clues from the history, like someone mentioning obesity, typical angina pain, getting short of breath more easily with activity, or needing pillows to sleep.
Orthopnea, you called it.
Yes, or waking up gasping for air, paroxysmal nocturnal dyspnea, or fainting spells, or that claudication leg pain. Those things should definitely trigger further investigation.
Like tests.
Exactly. Depending on the suspicion, it could be an EKG, especially for chest pain, blood tests looking for cardiac enzymes if a heart attack is suspected, maybe imaging tests down the line.
But the focus should be before symptoms start, right? Primary prevention.
Absolutely. That's where the biggest impact lies. Identifying people with risk factors, even if they feel perfectly fine, and working intensely to manage those modifiable risks.
So how early should this start?
Guidelines suggest starting young. All patients, beginning at age 20, should be talking with their doctor about CVD risk factors and getting their cholesterol levels, lipids, measured periodically.
Age 20. That's quite early.
It reflects that atherosclerosis can start early. The idea is to establish a baseline and track changes over time.
Okay. Then what?
Then we often use risk calculators. These tools plug in your numbers like LDL cholesterol, HDL cholesterol, blood pressure, age, smoking status, diabetes status, to estimate your risk of having a CVD event over the next 10 years, or sometimes even 30 years.
And that score tells you what to do.
It helps guide decisions, yeah. If your 10-year risk comes out above a certain threshold, often around 7.5% or 10%, that might trigger recommendations for medications like statins to lower cholesterol, or maybe low-dose aspirin for primary prevention, alongside lifestyle changes, of course.
Are those calculators perfect?
No, they have limitations. Our source notes, they might underestimate risk in people with diabetes or certain genetic high cholesterol conditions like familial hypercholesterolemia.
Okay.
And importantly, many of the studies used to create these calculators didn't include large numbers of people older than 79. So for older individuals, it's less about a strict score and more about an individualized discussion of risks and benefits.
So regular check-ins are needed.
Definitely. Reassessing CVD risk every 4 to 6 years is generally recommended for adults.
And what about the lifestyle stuff? That's for everyone.
Absolutely critical for everyone. Following healthy eating patterns, avoiding excess weight, staying physically active, these are foundational. And they become even more pertinent if you have non-modifiable risks, like that strong family history of early heart disease, or for women after menopause when risk naturally increases.
Are there newer tests coming along? You mentioned inflammatory markers.
Yeah, there's ongoing research into things like certain inflammatory markers in the blood, or getting a coronary artery calcification, CT score, from a CT scan. These can sometimes help detect subclinical atherosclerosis disease that's present but not causing symptoms yet.
So they might refine risk assessment.
Potentially, yes, especially for people in intermediate risk categories where decisions are borderline. But the key takeaway from our source is that these newer tests are still evolving and shouldn't replace the fundamental importance of identifying and managing the well-established, known risk factors we've discussed.
Got it. Focus on the fundamentals first. So let's say CVD is diagnosed. What happens then? What does management involve? And what are the really serious outcomes we need to be aware of?
Right. Once CVD is established, the treatment becomes very specific to the situation and the type of CVD. It's highly varied. Sure, for an acute ischemic stroke, it might involve giving clot-busting drugs or doing a procedure called mechanical thrombectomy to remove the clot. For severe PAD, maybe angioplasty or bypass surgery in the leg. For blocked coronary arteries causing symptoms, maybe placing stents to open them up.
So interventions are common.
They can be, yes, depending on the severity and type. But, and this is absolutely crucial, regardless of the specific procedure or initial treatment, the cornerstone of long-term management for anyone with known CVD is secondary prevention.
Meaning preventing another event.
Exactly. Preventing worsening of the disease, preventing future heart attacks, strokes, or other complications. This involves intensive education and support for rigorous risk factor control and lifestyle modification. It's non-negotiable, really.
Okay. And the complications if things aren't managed well or just due to the nature of the disease, what are the big concerns?
Well, the most feared complication, obviously, is death. As we said at the start, CVD remains a leading cause of mortality worldwide simply because it's so common and its consequences can be fatal. Beyond that, major complications include longer hospital stays, significant physical disability impacting quality of life and ability to work, and, as we touched on, huge healthcare costs, both for individuals and society. These costs are projected to keep climbing.
Are there specific complications for certain conditions, like heart failure?
Yes. For people with heart failure where the heart's main pumping chamber is weak, what we call HFrEF, heart failure with reduced ejection fraction, typically below 35%, there's a very high risk of dangerous heart rhythms.
Arrhythmias.
Exactly, potentially fatal ones. So current guidelines strongly recommend an implantable cardioverter defibrillator, an ICD, for these patients, especially if they still have symptoms despite being on optimal medical therapy. The ICD can detect and shock the heart back into a normal rhythm.
Okay, what about the aftermath of a stroke?
Strokes can leave devastating long-term disabilities. We mentioned dysarthria or aphasia problems speaking or understanding, dysphagia, difficulty swallowing, which can lead to malnutrition or pneumonia.
And muscle weakness?
Paresis.
Weakness on one side.
Often hemiparesis or hemiplegia weakness or paralysis on one side of the body. This can be temporary, but often it's permanent, leading to major mobility issues, potentially even being bedbound. And being immobile brings its own set of complications, like higher risk of blood clots, pressure sores, urinary infections.
That's a cascade effect.
It really can be. And for peripheral artery disease, besides the pain and limitation, PAD significantly increases the risk of dying from any cause. Other PAD complications include chronic, non-healing wounds on the legs or feet, severe physical limitations, and critical limb ischemia, where blood flow is so poor the limb is threatened, potentially requiring amputation.
It paints a pretty stark picture of why prevention and management are so critical.
Absolutely. The consequences can be profound and life-altering.
Okay, this has been incredibly informative, but also quite sobering. Thinking about the listener and the healthcare community, what's the big takeaway message here? How can we collectively work to push back against this disease and improve outcomes?
I think the biggest message, connecting everything back, is the overwhelming importance of primary prevention. We need to shift the focus. Leading a healthy lifestyle, eating well, these aren't just nice-to-haves. They should start as early in life as possible.
To stop atherosclerosis before it really takes hold.
Exactly. The goal is to delay, or ideally, completely avoid the initiation of that atherosclerotic process we talked about, because that's the foundation for so much future risk.
Is there a target to aim for?
Well, the American Heart Association has put forth this really useful concept they call ideal cardiovascular health. It's a benchmark.
What does that involve?
It's defined by having both ideal health behaviors and ideal health factors.
Okay, what are the behaviors?
The ideal behaviors are being a non-smoker, having a healthy body mass index, BMI under 25, meeting physical activity goals, and eating a diet that aligns with current health guidelines.
And the factors?
Those are the numbers. Untreated total cholesterol below 200 milli-GDL, untreated blood pressure below 180 milli-BDHG, and fasting blood glucose below 100 milli-GDL. Basically, healthy numbers without needing medication.
So it's a combination of lifestyle and metrics.
Right. And the AHA's overarching goal in promoting this concept is ambitious but crucial.
Yeah.
They aim to improve the cardiovascular health of all Americans and achieve a 20% reduction in deaths from CVD.
That would be huge.
Monumental. Of course, while that's the ideal for everyone, we need to pay special attention to those already at higher risk.
People with diabetes, hypertension.
Exactly. Diabetes, high blood pressure, high cholesterol, people who smoke, people carrying excess weight. For these individuals, aggressive risk factor modification is paramount. Controlling the medical conditions, definitely quitting smoking, working on weight loss, staying active, these are non-negotiable elements of their care.
And how does the healthcare system deliver this best?
The evidence strongly points towards an interprofessional team approach. It's not just one doctor. It's primary care doctors, nurses, dietitians, pharmacists, specialists like cardiologists and neurologists, maybe health coaches, all working together with the patient.
Does that really make a difference?
Oh, absolutely. The source cites strong evidence, Class 1A, for improved outcomes in heart failure patients managed by such teams. And another example showed a stunning 76% reduction in death from coronary artery disease in an intervention group that had this kind of interprofessional team follow-up compared to standard care.
76% reduction. That's incredible.
It really highlights the power of coordinated comprehensive care and education. Which leads to the final point. Everyone in healthcare has a role to play in educating the public, educating patients about these lifestyle changes and the importance of minimizing those modifiable risk factors.
It truly sounds like a collaborative effort is needed. Patient, doctors, the whole system. This deep dive has really hammered home the scale of cardiovascular disease, hasn't it? From atherosclerosis starting silently in childhood to the clear impact of lifestyle choices we make every day. Understanding the specifics, not just heart disease, feels incredibly important.
It really does. Knowledge is power here. And perhaps to leave you with something to think about this week.
Okay.
Knowing that CVD is still the world's biggest killer, and now having a clearer picture of what ideal cardiovascular health actually looks like, according to the AHA, what's maybe one small actionable thing you could start, or perhaps reinforce, in your own life this week? Just one step to move a little closer towards those ideal behaviors or factors we talked about. How might understanding the specifics of CAD, stroke, PAD, not just the general term, motivate you to take a more serious look at protecting your own long-term health?
That's a powerful question to reflect on. One small step. We hope this deep dive has given you the knowledge and perhaps the motivation to take that step. Thanks for joining us today. We'll be back soon for another deep dive.